They're starting at, I think my talk is at 7, but I think they're starting.
Should be finished by then.
It's okay.
Where is it?
Right here, starting. Starting.
As I start.
I think we're far away, Pete.
Okay, well, good afternoon, ladies and gentlemen. The man in your view there is Dr. Imraan Mia. Dr. Imraan Mia is a colorectal surgeon, and you can Google him if you like. There's a huge amount of credentials that he's got. I'm just going to say that he's a colorectal surgeon. Imraan is a man of substance, and his speciality is complex obstetric perineal injuries. In fact, Steve, the other day I was, we have adjacent theatres, and I'll go and have a look at his complex obstetrical perineal injuries. And it's amazing what he can actually do. It's amazing. Now, fecal incontinence is the topic tonight, and Imraan's presenting fecal incontinence, causes and surgical management. All of us, myself included, have had obstetrical fecal problems, and for this reason, you need to make friends with your obstetric fecal repairer. And for that reason, we're very, very privileged to have Dr. Imraan Mia and Dr. Tim Forgan at this hospital, and even after I was able to come and do repairs. We've got a whole lot of questions lined up, but I don't want to take the wind out of your sails. Imraan, it's been a great pleasure at last to have you with us, and we look forward with great interest to hearing fecal incontinence, causes, and surgical management. With me here is Professor Steve Jeffries. He's one of the 10 best. I rate him as one of the 10 best urogynecologists in Cape Town. So for that reason, he's going to be co-chairing with me. And Steve, welcome.
Thanks so much, and thanks for giving me such a high rating as always. Yes, it's a great privilege to have Imraan with us. Imraan is a subspecialist colorectal surgeon and been working with us here at Chris Barnard for a few years now. And I must say it's been wonderful to have such a strong team with him and Tim Forgan assisting us here with the colorectal pelvic floor problems that we're having. And Imraan is eminently available to assist with a full range of issues night and day, and we really do appreciate your willingness to help and the competence and the spirit with which you bring the assistance to all of us here at Chris Barnard, Imraan. But without further ado, we're looking forward to hearing about this very important issue. And I see these patients myself, and they are some of the most destitute and desperate patients. To have a solution for them is a wonderful thing. So yeah, we look forward to hearing your approach, Imraan. Thanks so much. And I think you can start sharing your screen and fire away. We will interrupt you going along as the spirit of these webinars.
Please do.
In the chat. So often a little bit of discussion along the way.
We've already got a few questions, but let's keep them for the end, or if your topic comes up. So Imraan.
Yeah, great. Thanks so much for the introduction. Yeah, it's great to work with both Peter and Steve at Chris Barnard with these cases. And, having a colorectal surgeon, you need a good gynae and urogynecologist around as well for these problems because they're often multi-compartment. So I'm going to take you through a talk on fecal incontinence. And as you said, with colorectal as well, we've got a similar philosophy. As we go along, just shout if you have any questions. We're quite open to interruption and going for it. All right, can everybody see my screen?
We can.
Okay, great. So just as a bit of background, fecal incontinence is defined as recurrent involuntary passage of rectal contents. So it's that sort of inability to delay evacuation, and they have to be present for at least a month. There's various types. There's urge, passive, and seepage. Urge incontinence, often, difficulty to constrict the external anal sphincter, and passive, voluntary without any awareness, and seepage, normal or leakage of stool with normal continence. Often with these patients, it's quite difficult to talk to them about it. And as Steve said, these patients are often quite destitute and quite sort of at their wits' end by the time they come and seek medical attention. And most of it is often due to embarrassment. I see a lot of women that come and see us for incontinence, and they so embarrassed about it, they don't bring their partners with to the consultation because it's something that they feel extremely uncomfortable, discussing the magnitude of the problem. One of the ways to sort of break the ice in some way is just to chat about accidental leakage. I find, if you talk about leakage rather than incontinence, people feel that they aren't as sort of, disabled in a way. They have a problem, but it's something that we can try and address. And obviously the incidence increases with age. I do see it, obviously related
Sorry, Imran.
Yes.
That
Yes.
incidence there, is that in males and females or just females or both?
This is predominantly females. It's a predominantly female problem, and I'll show you why, just based on the type of or the causes of fecal incontinence. But these incidences here are for females. So we do see a number of young women, but the majority are as you get a bit older. Most commonly, these are due to obstetric trauma, and that's why this affects women more often than men. One of the scary things that I, think about if somebody's having a normal vaginal delivery is that there's a almost 30% chance of an occult sphincter injury. So somebody who's had just what seemingly is a normal delivery may have an underlying sphincter injury without any symptoms, which may then present later. More common in multips, and obviously with instrumental delivery, the incidence of sphincter injury increases quite dramatically. But obstetrics and childbirth are not the only things that we can blame. It's a complication of surgery as well. And surgeons, colorectal surgeons and general surgeons do a lot of these procedures, hemorrhoids, fistulas, and prolapses, which if we look at the anal canal, the hemorrhoidal complexes of veins are really, really close to the internal sphincters, and it's quite easy for somebody to overzealously cause a sphincter injury. Previously with things like fissures, they used to do lots and lots of sphincterotomies as well, which have sort of fallen out of favor with the introduction of things like Botox. And then other surgery, this IPAA is an ileoanal pouch, which we do very rarely for severe inflammatory bowel diseases or bad cancers. And then one of the other things to consider is that it may actually just be a secondary symptom. So pruritus ani, the itchy bottom, is something that people complain about a lot. And underlying, there may be an element of mucosal prolapse as well as an element of leakage or seepage. And then the other one, recurrent UTIs, is something that we see a lot of as well.
Imran?
Yes.
Imran, if you could just go back to
Yes.
pruritus ani. What
Yes.
causes pruritus? I see quite a few women that scratch, and
Yes.
I said to one the other day. But what
Yes.
actually causes this?
Yeah, so pruritus is not really an inflammation problem. It's a problem that is perpetuated by repetitive sort of trauma to the anus. So often it's women that have this sort of feeling that they're unable to clean themselves or have a little bit of leakage. And often the underlying mechanism is there's a little bit of mucosal prolapse or some minor leakage. And what we often find is that you have to break the itch scratch cycle in a way. And with the sort of itch, the desire to scratch is there. And, with a little bit of leakage, they often find that they can't clean themselves adequately. And so they use multiple efforts with paper, and toilet paper is your enemy when you've got pruritus ani. So, they say that when you've got pruritus ani, the best thing is to get a hand shower or bidet or peri bottle of something of that nature. And if you're really luxurious, the best way to get rid of it is with Egyptian cotton rather than toilet paper. But obviously not very accessible to everybody.
Egyptian cotton.
Yeah, apparently the finest thing. It's much better than 2, 3, 4 ply or whatever you've got.
Okay.
All right.
Thank you.
Good. Some of the other causes of fecal incontinence, there's a whole list of different ones, from neurological causes and spinal cord injuries or surgery or neurodegenerative diseases. And then, congenital abnormalities that we can see, and then some gastrointestinal things, which we see some more often, which would be inflammatory bowel disease, things like Crohn's disease. And you may see it more commonly in women that have had radiation for cervical cancer. Radiation proctitis is quite common and can happen many years after the completion of radiation. And then other things such as tumor and neoplastic conditions, and then one thing that we must always just try and remember is just some of the medications. We have I think Steve and I have spoken a lot about constipation, just to each other, about how we can try and rid the world of constipation. And I think the use of diarrheal agents is very widespread. And I think that's something that you've got to take a good history and make sure somebody's not over-medicating themselves. So where do I start? So if I see somebody with fecal incontinence, the big thing to start with is, once you've taken a good history, is, do a good physical examination, look to see if you see any fistulae, rectovaginal fistula, perianal fistulae, hemorrhoids, fissures, and then obviously prolapse is important as well. So whether they've got some mucosal prolapse or a full thickness prolapse. And it's quite important to, take time, and when doing a rectal exam, you've actually got to get the patient to bear down while you're examining them to see if there's any degree of prolapse. And you may need to get them to stand in order to demonstrate the prolapse. I said there, sort of assess resting and squeeze pressure, and we'll come to how we can do that. But, just clinically, your digital rectal exam is a pretty good indicator of what sphincter tone is like. We have got some more techniques that we can use. And then nowadays we use endoanal ultrasound a lot to look for sphincter injuries. And I think that's probably the gold standard way, and probably the most cost-effective way. And MRI is obviously more expensive and has limited access. But an endoanal ultrasound is a good way to assess sphincter tone and sphincter integrity. So imaging is sort of giving you an anatomical idea of whether something looks and appears normal. And then functional testing, which is something that I'll show you now, is looking at function of the sphincter. And EMG is something that we don't do that often anymore, but manometry is something which is very useful. And I'll show you some slides on manometry. And anal manometry is something that can be done in the rooms and can give you valuable information about both internal and external sphincter function, as well as sensitivity of the rectum.
Sorry,
Yeah.
To go back, did you want to ask something?
Yeah, actually, thanks, Peter. Imraan, I've often wondered,
Yes.
in my own practice, you see the patients with a big rectus seal with some fecal incontinence, and they certainly want the prolapse repaired. Often they've got a valve prolapse, and you can do something like a sacrocolpopexy. I always advise them that, the fecal incontinence would most likely not get better, although I must say we do see that it gets better. I have often done a interstitial one, I'm sure we're going to talk about that a little bit later, and a prolapse repair.
Yeah.
What is your thought on a rectus seal and incontinence? Where do you fit in terms of thinking about it?
Yeah, look, so I mean, there was one study that they did looking at rectus seals, and it was like sort of a young cohort of British women, and they found that young women under 30, about 20 to almost 30% of them had a rectus seal without any symptoms. So I think the rectus seal is important if they've got symptoms. They often, present with like sort of obstructed defecation rather than, just pure incontinence. But obviously, that inability to empty that little pocket may cause a degree of incontinence. And I think I think it's well worth trying, as a sort of inexpensive way, instead of trying to do an interstim, I think trying to correct the anatomy in some way first. If you've got just a rectus seal and no other anatomical problems, I think, it's probably worthwhile trying to fix the rectus seal to see if that'll help, just to get rid of that little pocket of residual stool, which may contribute to their leakage.
Okay, thank you.
Now, Imraan, my question was this. I see in your investigations, there's no mention of that old favorite difficography, X-ray difficography. Has that fallen off the wagon, Or do you
No,
think
so I've
you
got a few slides later on about difficography, and we will talk about it. It hasn't fallen
Okay.
away by the wayside. Radiologists have driven it slightly in a different way, that they'd like you to do an MRI difficogram rather than a barium difficogram. And I think that's purely from a financial incentive from their side, more than just purely from a functional testing point of view. Although
Okay.
MRI difficogram does give you excellent imaging. But we'll talk about it in a second.
Okay, thank you.
Perfect. So I've put here sort of the modern colorectal surgeon should offer endoanal ultrasound. I think, it's something that I'll show you a few pictures shortly, is really, really invaluable. And I think, just, when we look at MRI, it's a great tool, but, when you've got an ultrasound, and obviously obstetricians and gynecologists are well versed in ultrasound, but, for us as colorectal surgeons, it's something sort of slightly new and not used as often. And I think it's sort of massive game changer. And I think, not only for sphincter imaging, but also for early rectal cancers. We've seen that with early rectal tumors, the ultrasound is actually superior than an MRI. One of the things to consider is, we said about almost 30% of women will have an occult injury after vaginal delivery, is, whether or not we should, somebody who's had a difficult labor or prolonged labor, that, should they have a routine endoanal ultrasound just to evaluate their sphincter, because, maybe that will sort of infer some implication on what to do in their future pregnancies. This is what the endoanal ultrasound looks like. This is the BK ultrasound machine, which is sort of the gold standard machine for endoanal ultrasound. There are different ones, and there are sort of probes that are similar to vaginal probes, which can be used, but this giant lance of a probe here is the endoanal ultrasound probe of choice. It's basically got a little crystal within the endoanal ultrasound probe, and so the probe itself sits in the anal canal about 4 or 5 centimeters in, and the crystal moves back and forth and creates a 3D image of the sphincter complex. So this is the type of image that we get, and you can see let's just see here. I can, oh, actually, I don't want to annotate. It's okay. Never mind. So what we can see is the eyes indicating where the probe is, and there's like a little bit of gel and a condom around it. And then the first little white line that you see is the mucosa of the rectum. And then the little darker ring around that is the internal sphincter. And then the lighter ring around that is, again, the external sphincter. And what you do is you can kind of assess in different levels and try and see how thin the sphincter is, if there are any defects. And in this image here, we can see that there's an internal sphincter which seems intact, and then an external sphincter where it looks like there's a tear where the arrow is indicated. So endoanal ultrasound, great tool, and it can be done in the rooms. No need for any MRI testing really for that. The other imaging that you asked about, Peter, is difficography. So difficography is really valuable, and I think one of the things with incontinence is that as part of the multi-compartment approach of pelvic floor surgery, is that you often find that although there's incontinence, they may actually have prolapse or a cystocele, or one of the other compartments may also be a problematic. So the MRI and the fluoroscopic difficogram both give you very good information about prolapse and internal prolapse or intersusception. The difference with the MR is that the MRI, the patient lies on their left side. So it's a bit of an unnatural position for them to have the paste put into the rectum and then have to try and replicate defecation while you're on your left side, sort of in an MRI machine. Whereas the fluoroscopic one is you sitting on a commode for all intents and purposes and having a more normal position bowel movement. But obviously with MRI, you can have a good look at muscles and look at all the other sort of compartments, bladder, vagina, uterus, without having to re-image. So I think MRI is still although costly, it gives you a little bit more of a universal kind of overview of everything, of all the compartments. So I think that would be our go-to still. The other test that we spoke about is manometry. So manometry is now something which this company here, THD, tried to sort of implement, and this was a sort of in-room manometry, sort of very small footprint, and basically you had this little machine which had a balloon catheter, which would give you basic understanding of manometry and internal and external sphincter. The problem with this machine was there's a little cartridge that you needed to use it, almost like a little SD card, and it only lasted for 10 or 15 minutes, and it was single use. So it became difficult to really assess sphincters because it was just a bit too quick. So what we do use now is either water perfused machines or solid state machines, depending on how much money is available at your hospital. And basically it's a water perfused catheter, which has different amounts of channels which measure the anal canal, and it's slightly longer learning curve to get used to it. You know, you can probably, you know, if you're very busy, try and get somebody as a technician to come and do manometry. It takes about 30 minutes in the rooms. The only thing the patient has to do beforehand is just make sure the rectum is empty. They don't necessarily have to have an enema beforehand, but can just have had a normal bowel movement in the morning before if they can. And generally it's quite forgiving if they haven't had a massive bowel movement. But, you know, if there's stool in the rectum, unfortunately they have to then have a small enema just to get rid of that stool, so we don't have any confounding imaging. And this is roughly what the imaging looks like. It basically gives you measurements of different pressures, and you can see sort of resting pressure, and there's a whole host of tests which you can do, including squeeze pressure, push pressures, cough, and, you know, the sensation of the rectum. And essentially there are a varying degree of standardized sort of parameters that you can look at. Most of them are defined for women. So if you do have a man, which obviously the majority of the audience wouldn't necessarily encounter, but for men, it is a bit more tricky to interpret the pressures, and we have to sort of infer slightly differently because the male sphincter complex is slightly longer than the female. Okay, well, that's just mainly the sort of just talk about how we work them up essentially. So I don't know if anyone has any questions about investigations before we move on to management.
Imraan, I'm just checking. Yeah, here's a question.
Yeah.
Does Ronald Lawrence says, does transperineal ultrasound have a role in assessing external anal sphincter injury?
Yeah, look, I think you guys are very good at transperineal ultrasounds, and I've done a few where we've had combined clinics where you can get very good imaging from transperineal ultrasound. So I think it is a good tool to use as an adjunct. You know, the problem with this ultrasound, the BK ultrasound machine, is that's become exorbitantly expensive, and so even hospitals are reluctant to buy it. It's now something like 1.7 million rand for the machine and the probes. So it's become, you know, a very difficult thing to manage and replace. They've recently updated the machine slightly and made everything not backwards compatible. So if you have something that's not working on your BK machine, you've got to replace the whole thing. So it's I think transperineal ultrasound is still valuable, and I think you can get good imaging about you know, if you've got an occult injury. If you see something, we can then tailor investigations to that thereafter.
Thank you.
Excellent. All right. So this is a picture that you've got to have up in your rooms, which is a Bristol stool chart, which is basically like something to give someone to obsessively try and achieve, to try and get a sausage or a smooth sausage-shaped stool. So the non-surgical things that we advocate is, you know, just to try and get to that type 3 or type 4 stool consistency. And we often involve a dietitian just to see if they have any sort of underlying food intolerances or allergies which may not have been seen before. And then we advocate sort of 20 to 30 grams of fiber intake. Water is a difficult one. You know, some people are obsessed with their Stanley flask and want to drink at least 3 liters a day. We just sort of advise drink to thirst. There's no real massive, difference if they have 2 or 3 liters of water a day. Psyllium is a very good adjunct to helping dietary optimization, very low long-term sequelae. So randomized trials comparing psyllium with loperamide, had equal fecal incontinence response with less constipation in the psyllium group. So, psyllium is quite a good one. Loperamide, we do about at like Smarties, loperamide you can in our patients who have complicated fistulae or stomas, we give up to 16 loperamides a day. So you can go up quite a lot. This was just a little table where they looked at different medications and basically fiber and loperamide had, sort of level 2 evidence. And then a drug that we use quite frequently, which is amitriptyline, and that's usually used for our IBS patients. Sometimes you have a little bit of overlap with incontinence and IBS. They are, the IBS diarrhea type group, and then low dose amitriptyline can be quite effective in those patients. The next few things are things like pelvic floor physiotherapy and biofeedback. Very important to have a good pelvic floor physiotherapist working with you. Not just doing Kegel exercises, but also, trying to use EMG and manometry to try and stimulate specific pelvic floor muscles to enhance function. Something which they use in the UK fairly often are anal plugs, which is basically like an anal tampon. If somebody's got minor leakage, this is a sort of low sort of risk thing, minimal intervention, and basically just offering them an anal plug if they don't have access to nerve stimulator or don't have any other options.
Do we have them in South Africa, Imraan?
Excuse me?
Do we have them in South Africa?
Anal plugs.
Anal plugs.
I mean, not specifically, there aren't any specific type ones. I've hardly ever needed to, prescribe them to anyone. I think the majority of patients are very sort of unhappy to kind of plod along with just an anal plug. But I think, you can try and use something similar to a tampon, but, essentially most patients just end up with a liner or something of that nature.
Okay.
The other things which are bulking agents, bulking agents also very sort of low risk, but also poor long-term success. So you can use submucosal infiltration with the idea that a larger looking sphincter complex may work better. But repeat injections and long-term outcomes not great. Then with regards to surgery, a few different things that we have in our repertoire that we can use, and we'll talk about them shortly. One, the surgical ones that we do often is sphincteroplasties and rectovaginal fistula repairs, and then obviously prolapse surgery, which might be multi-compartment. And then one or two things that I'll show you using non-resective or non-mesh procedures, such as collagen and then more bulking agents. So the sphincteroplasty is one which is quite tricky. I think the other day when Pete walked into our theater, we were repairing somebody's very complicated tear who was told they had a first-degree tear, but it actually sort of destroyed their whole perineal body. And they initially were seen and then presented within a week to another hospital, and they said best to delay. So having a look at it, there's not, a lot of literature about how long you can sort of how long is too long before you say, look, we have to wait. But there was one study where they said, early repair within 14 days of a dehyst repair, is feasible, not great data, and just from a single center, but it said, if you've had a dehisced repair within 14 days, the likelihood of it re-dehiscing are less if you do it in 14 days. So really useless information. The majority, would say still wait 3 months if you've gone beyond 72 hours.
Sorry, Imran.
Yes.
Yeah. So it means, if I may say,
Yes.
early versus delayed repair. Excuse me. If a woman has a vaginal delivery and damages her anal sphincter and has what we used to call a 3rd or 4th degree tear.
Yes. Yeah.
So it's still best to repair it immediately. Who should do that repair? The gynecologist, or should we call you or your friend Tim?
Yeah, look, I think, the who does the repairs, I think probably, the way that we do the repair is probably the most important. So whether a gynecologist or obstetrician who's done many has done them is probably the same as if a colorectal surgeon does them. I think the principle is to identify the sphincter complex very well, and then to try and do this overlapping sphincter repair. And if it's something that you feel very uncomfortable doing, then, rather just call the colorectal surgeon and let us have a go. It is a very unforgiving thing. When you do any proctology, we always tell patients that wound healing is terrible. Wounds do dehisce more frequently, regardless of what the pathology is. So, inherently, if you've seen them a lot and done them a lot, then do them. I think the big principle is to make sure that you try and get this overlapping repair, which I'll show you in a little second.
All right. So we must do or if we can, we do the primary and the delayed broken down one. We give you a shot, basically.
Yeah, I think that's a good way to think of it. Yeah.
Okay. Thank you.
Good. So this is similar to what we saw the other day, and it's basically where you've got almost like a cloacal type deformity. This person is lying prone just for orientation. So the top of the vagina is up there and the natal cleft is back that way. But essentially there's a loss of the perineal body. And in these patients, we try and, you can imagine that the sphincter is now sort of almost C-shaped rather than completely circular. And we try and dissect the perineal body and then get an overlapping repair. The big thing with the overlapping repair is to decrease, if you're doing it delayed, is to try and get all that scar tissue removed and get rid of all the scar tissue and release the sphincters laterally as widely as you can, so that you can get about a 2 centimeter overlap. And you need that overlap to create this sort of high pressure zone so that it can tolerate a bit of pressure. We usually use sort of 3/0 PDS interrupted sutures, and some books describe using 4 interrupted sutures being adequate. One of the big things in these type of patients with these cloacal kind of defects is reconstructing the perineal body to try and separate the anus from the vagina again. Because if you have 2 suture lines next door to each other, we try and get them separated as much as possible in order to allow them to have the best chance of healing. So the 2 questions are, when to use a flap and which flap is best. Just about sphincteroplasty, sphincteroplasty has a good 5-year results, but the results do wane after about 5 years. So it is something that may need sort of adjunctive pelvic floor physiotherapy and may eventually need other treatment if incontinence happens again. With regards to flaps, I think the one thing there, as I said, is to try and recreate the perineal body to prevent that sort of anovaginal reflux. In rectovaginal fistula surgery, which we do fairly often, is that it's just to create a barrier between your rectal and your vaginal suture lines. With complicated reconstructions or anyone that's having a redo operation, we always recommend a diverting colostomy. I think that stool diversion just takes away some of the pressure of your repair. You're not sterilizing the perineum in any way, but I think just the diversion of the stool takes some of the pressure away. anecdotally, our plastic surgeon says, he had one that he remembers where they did a big flap and no diverting stoma, and the whole thing broke down, and she had stool draining out of her leg essentially from the graft harvest. So it's something that
was that a gracilis flap that?
Yes, yeah, there was a gracilis flap that had just, the whole tunnel and the whole wound had given way as a result of just that small amount of dehiscence of the suture line, which usually happens in the rectum, in the anus, and that just becomes unforgiving if there's lots of stool passing through.
Yeah.
So these are a few pictures that Dr. Price has allowed me to share, and he's our plastic and reconstructive surgeon at Chris Barnard, and he helps with a lot of these reconstructions. And this is one which when I did my fellowship in colorectal, that the urogynecologist at Tygerberg advocated quite strongly, is a Marsh's flap. And it is actually quite a nice, robust flap. You can see the large amount of tissue that you can harvest. And is quite a useful one to try, probably as your initial sort of approach, rather than doing a gracilis as your initial approach. But just depends on the sort of severity of whether you have a fistula, whether it's a urethral fistula or a rectovaginal fistula. The next one is a gracilis flap. So this is just the markings of where we sort of harvest the gracilis muscle. It's important to see this sort of area that marked between 8 and 10 centimeters from the pubic tubercle is where the vascular supply is of the gracilis muscle. There's a few variations on the blood supply, but in general, that's where it comes from. And it's also important just to, recognize the gracilis and not take the sartorius muscle, which can be done from time to time. There are a couple of ways to do it. You can do this big open cut on the leg, or do a couple of small incisions and then release the muscles through those smaller incisions. And I think as long as you're happy with that you've identified the gracilis muscle, either one of those incisions is actually fine. And I think these wounds tend to heal really well. We do have to leave it drain, but the scar generally heals pretty well. And for the most part, most women that we've done this procedure for have been happy to have this big cut, despite what it looks like. And here in this picture, you can see that the muscle has now been tunneled through subcutaneously and put in between the rectum and the vagina. And one needs to just make sure there's absolutely no tension on the muscle so that it doesn't retract. It does look very robust in the beginning, but it does atrophy with time. So in the beginning, they may have almost what looks like a Bartholin's bulge type thing. But after a few months, that sort of atrophies down and gets a lot better. And sort of in this picture here, you can see the sort of defect between the vagina and the rectum and the muscle being delivered in between. And then that wound being sutured either transversely or longitudinally. It just depends on what your perineal body looks like. If the perineal body has been scarred, you may suture it longitudinally just so you can create a little elongated perineal body to create a bit of space between the rectum and the vagina. And at the end, they've got a drain in the leg, in the upper thigh, and a urinary catheter, and can go home after 2 or 3 days. The biggest part of their stay is making sure there's no seroma in the tunnel, because any fluid that builds up may cause dehiscence in the flapped muscular area, and then these patients usually have a colostomy, so they need a bit of time just to get used to their colostomy. Okay. One that I came across recently is something called an X flap. This is again a person that's lying prone, and here it's just basically like a local advancement flap to close a cloacal deformity. So just a local advancement flap to help create extra tissue there. The next things were things about prolapse surgery, which is something that may present with incontinence. And so here, I know that Steve is very good with sacral colpopexy laparoscopically and finds the robot almost something that hinders his time of operating.
It makes him go much slower when he uses a robot.
Yes, yeah, he does
Like
feel like
robots, he never
he
stops
does
it.
feel like he's stuck at the robot. Yes, but
Yeah.
for with mesh rectopexy, we really need to put sutures down onto the perineal, onto the pelvic floor. And so for us, suturing down low down in the pelvis is it's sort of a dream with robotics, much easier than laparoscopy. When patients ask about mesh and mesh in the pelvis, there was from a European Society of Coloproctology put out a statement about pelvic mesh, and they've advocated the use of PVDF, which is polyvinyl diene fluoride mesh, which is the Dynamesh, which they've advocated as safe for rectopexy. And often patients will still, sort of want to discuss, all the litigation around mesh. And I think one needs to just have a good open discussion, because one doesn't want to have a mesh erosion in the one patient you haven't had this discussion with. But PVDF from a colorectal society point of view is approved, and we're happy to use it. Some of the other funny tools. So this tool is a sphin keeper or a gatekeeper, and essentially it's a sort of expandable implant which goes between the internal and external sphincter muscles. It's not available in South Africa in the private sector or public sector, but in private it's not been approved by medical aids for use. I tried to get this because I saw it at a conference overseas that people were using it quite well for people that couldn't access Interstim. And so I thought I'd try and get one for somebody here. And it turns out it's 10,000 Rand cheaper than the Interstim. So it's pretty much the same price at like 120,000 Rand for the device, which is pretty exorbitant. Also has fairly good outcomes, but basically just creating a bulky sphincter. And then these anal slings. The only picture I could find of an anal sling looks like it came out of a very old textbook, which hopefully is where this operation stays. So we won't talk too much about that. And then one of the last things I wanted to talk about is just the sacral nerve stimulators. So I know in gynae, you guys would use it a lot for urinary incontinence, and from a fecal incontinence point of view, the outcomes are excellent. I'll show you some studies about that. For those of you that have used them before, this will just be a little bit of reiteration of the same information. And basically, it's a two-step procedure. We do a test phase, and then 2 weeks later, place the implant. Very low risk procedure other than the cost, and one that I think works very, very well. The mechanism is still sort of somewhat unclear. It seems to upregulate sensory function with both afferent and efferent pathways. The big advantage is minimally invasive. The test phase, allows some evaluation of response, but it's only like a 2-week test phase, but it is, it does give you some indication of which direction things will go. And often you see when patients have got the test phase in, once the reps cut the lead, they only then notice that they actually had a big improvement in their symptoms before you put the implant in. We don't use too much percutaneous nerve or posterior tibial nerve in evaluation, but it is something that can be used as well. Just a picture of where it all goes. What does it all say? Lots and lots of studies, millions of studies about how it affects your fecal incontinence scores. Basically, just to show you that there's loads and loads of studies out there. But one of the places that was of interest to me was, after rectum cancer surgery, they had good outcomes in patients who had what's low anterior resection syndrome, and that's basically where they've got urgency, leakage, and frequency, which is basically where there's incontinence. And they said, they had 67 to 70% improvement post SNS. and the scoring systems are slightly different for the large patients as incontinence, but essentially very good outcomes in a small group. And again, they're again looking at low anterior resection syndrome, so people that have had their rectums removed, where they have a low anastomosis, very good outcome after closure of their ileostomies. So good outcome in comparison to just basically biofeedback training. So in summary, fecal incontinence is something that's obviously a lot more prevalent than we think. I think it's one of those conditions where physically is debilitating, but psychologically a massive impact. A lot of people become sort of reclusive and isolated because they don't have good function and good social confidence. Should we be looking a little bit more for occult obstetric injuries? I'm not sure. It may give you some assurance, but if you have a difficult delivery, I think it's valuable just to evaluate the sphincters when you're doing an ultrasound next. We've got a lot better anatomical and functional assessment than just the traditional old rectal exams. I think, one can get a more objective way of looking at things. One of the things with manometry, which is useful, is we can, do a manometry and say, look, do pelvic floor physio for 3 months and come back and we'll do another manometry and we'll see where you are in terms of objective functional improvement. And I think that's something of value that we can use more of. And the one thing that is also sort of in my mind is just, correcting the anatomy is not always the sort of main aim. We might find things which are not exactly like the textbook, but often we need to just take a step back and see what the symptoms are. And management of these problems can be managed in so many different ways now. So, don't just give the old biofeedback and dietitian and that's it. And obviously still the biggest thing impacting all of these is cost. But all in all, we've got a wide array of things that we can now offer for fecal incontinence.
Thank you very much indeed. That's wonderful, wonderful exposition. And Dr. Percy Moodley says, an excellent webinar. Thank you. Amira Furlyun says, Steve, are there any new developments in artificial sphincters? I suppose that's artificial anal sphincters.
Yes, yeah. I'm going to stop sharing my screen if that's all right. So there was a device or something called a magnemosis, which is like a magnetic ring, which was something which they were initially sort of playing with in that sort of in the similar vein as stool bulking agents. They were trying to see if they could have, with the bulking agents, when the rectum gets lubricated, when you have to have a bowel movement, those bulking agents expand. And I think it was a similar sort of thing with artificial sphincters. We don't have a good artificial sphincter yet, but there are these magnetic devices which are being touted as well, but not a lot of literature around them yet.
Another thing over here, you alluded to it. I think one of the most important things in preventing long-term outcome disability is training, especially midwives and trainees, as to how to diagnose a anal sphincter injury. And we do have regular workshops at SASOG. In last month in Sun City, we had a workshop, and you mentioned earlier on Abdul Sultan and Rani Thacker. They came out. She's the president of the Royal College of Obstetricians and Gynecologists, and she came out and they conducted a workshop on exactly how to diagnose and then treat anal sphincter damage, injuries, and repairs. And for those people that are interested, exactly a year from today, we've got anal sphincter repair aficionados. That's Abdul Sultan and Rani Thacker. They're coming again to the FIGO meeting. And if you wish to learn the skill on how to actually never miss one and how to repeat it and how to repair it, then you are well advised to register for that workshop, Steve.
Okay, thank you. Yeah, the other question that I had already was, where do you draw the line in terms of your investigation? I think we know that when it comes to interstim, the only real way of knowing whether it's going to work is by actually doing a trial phase. And so I probably tend to do less investigation than a lot of other people in terms of the manometry and even, in ultrasound, because we know that even when those things are quite low, or when you've got a very low pressure, that it will often still work. What is your feeling about actually the bare minimum in terms of investigations for these patients?
Yeah, look, I think, from a colorectal point of view, interestingly, the only requirement that they have in the European Society of Coloproctology is that you have a colonoscopy. And
You have a what?
A colonoscopy. Yeah. So for the older patient, who's now had a change in bowel habit, suddenly they've got incontinence, or, it's been slowly progressing. It's just to exclude that they don't have a malignancy, essentially. The manometry and the inner-anal ultrasounds are sort of nice to haves in the actual workup. And I think at a recent congress, they spoke a lot about how InterStim is sort of moving earlier in the phase of management, rather than being sort of a last step kind of procedure. It's now sort of almost being thought of as something that you can implement early. So having the manometry is nice, and I think it's it's a nice to have, but often, like you say, it doesn't necessarily change your management decision all the time. I think we have a good idea based on their symptoms and history. I think just as important, just from a bare minimum, is that they've had a clinical examination and a colonoscopy or flexible sigmoidoscopy to make sure there's no new malignancy.
So, I think a lot of us tend to go quite early. I think, and the role of a sphincteroplasty is really changing very quickly. Hey, you rather go for a InterStim than a sphincteroplasty. Most patients who come with fecal incontinence, isn't it?
Yeah, definitely. I think, I think the sphincteroplasty, I think it's such a high-risk procedure, the amount of wound dehiscences and things we've had. And, you often see somebody who's had a scar there for many, many a year, and you try and excise that and recorrect it, and you don't really enhance function that much. So I think we sort of veer away from sphincteroplasty unless they've got, these bad obstetric injury or sort of a cloacal type defect.
Yeah. And the medical aids are covering the InterStim quite well, with appropriate motivation. And it's not
you
like
put in quite a few, don't you, Steve?
I do. And obviously I do consult Imraan on regularly on a lot of them. But and as I say, that's why I just wanted to check, what do we need to make sure we're missing that we're not missing.
Yeah.
But I think and also for those with a lot of urgency in urinary incontinence and fecal incontinence, a wonderful option. We call them double incontinence.
Yes.
But in fact, if you've got a patient with fecal incontinence, the medical aid is less strict in terms of the criteria. With urinary incontinence, you need at least 6 months of conservative treatment, especially with an anticholinergic or betmeager. But if they've got some fecal incontinence, in a funny way, it's quite a relief, because you're going to get the device authorized a lot quicker, whereas you don't need to jump to a lot more hoops.
Yeah, they are still. The medical aids do still want the patients to have had diet, loperamide, and a bit of pelvic floor physiotherapy before they give you authorization for the fecal incontinence. But yeah, it might definitely be less strict.
I'll send you my letter.
It's been wonderful having you, Imraan.
Yeah,
I've been to Imraan's rooms. He's my neighbor, not only in theatre but also in the consultation. He's got these very, very high-end 7-star rooms, rather like one of your high-end hotels, 7-star hotels. Imraan, but I must say, you've got these magnificent graphics and these wonderful wallpapers and beautiful pictures, but I've never seen the Bristol stool picture in your office. I think that you said we all have to have one.
Yeah, no, it's in my drawer. It's just based on
you keep it hidden.
Practice management decided we can't have those types of pictures on the wall.
No, quite right. You're just going to upset people. That's quite right. But Imraan, it's been wonderful having you here. And this afternoon, I'm just going to ask Steve to thank you very much formally.
Yes, thanks so much, Imraan. I'm just looking at your the work that you're doing with the gracilloblasties and the cloacal defects. It's wonderful, and also just having seen some of those patients. We managed one in the last week or two, and again, the outcomes are actually wonderful. So
Yeah.
these guys are making a big difference with those surgeries, not only functionally but cosmetic and anatomically. So congratulations on that. And I mean, that's a really important part of patient management. So thanks for sharing those
Yeah, no problem.
results and your approach to that as well.
Do you have a Bruin and Kelder? I can never say that word. Bruin and Kelder ultrasound machine. Do you have access to one?
We have one at the hospital. There is only one. So I do have to share it with the liver surgeon because there is a very good liver probe that they use for laparoscopic liver resections.
Yeah.
But we have got the machine. Yeah, I think there are. I mean, quite a few hospitals around do have them. The only difficulty comes when, if there's a problem with the machine now that they've updated it and they've increased their price so much.
So it's a wonderful tool, but it's a bit impractical and a little bit exclusive to.
Well, yeah, I mean, yeah, I think even internationally, I think, we had on one of our colorectal groups, we had a discussion recently, and somebody in Europe was also struggling with after sales service, a part that had just sort of a cover that had just come off, and they couldn't get anything more without replacing the whole thing. So I think they've kind of geared it towards hospital groups buying them rather than individuals. I think it's a little bit.
Yeah. Now, Imraan, what about China? I mean, in our scans, the obstetrics and gynae guys, we've had a huge advance in Chinese ultrasound machines. They're made by the group called. Anyway, so don't the Chinese make B&K machines? Because don't you find that apart from that, that'll be half the price. It'll make it more practical and more accessible to the general population.
Yeah, there's a few similar sort of type machines. The problem is none of them have been able to replicate the 3D image that you get.
Okay.
And then also the sort of crystal technology where the crystal moves back and forth is something which seems to be exclusively to BK, whereas the other machines you actually physically move the probe back and forth. So it's not as a comfortable experience for the patient if you have to repeatedly image. So it's a little bit less available. There are things that you can use for basic imaging, so you can get similar type machines, and there are urology probes that they use for prostate biopsies, which have similar, but they're also not completely three-dimensional as well. So you can get a similar type machine.
Well, Imraan, thank you very much. I know you have the flu, and I want you to go back to bed immediately. And thanks once again. Also, thanks to Steve for being here. He's got to go and give another talk now. I'm going to go and do a vaginal delivery now. I'll be careful with the sphincter. And we look forward to seeing everybody, same time, same place, next week. All the best. And good night.
Thanks so much for the invitation.
Thanks, all the best.
Thank you,
All right. Cheers,
Bye, Imraan.
Bye.
Thanks. Bye-bye.